Next, I have Dr. Virginie Plante, who's going to wow us with the field of neurocritical care and how we are using point of care TCDs for neuromonitoring in the pediatric ICU. Virginie?
Thanks, Artie. All right, so I'll start right away. So I'm going to be talking about TCD in the PICU, but more precisely point of care TCD as a neuromonitoring tool. I don't have any relevant disclosures. And so why would we do TCD in the PICU? Typically, when people think of TCD in the ICU, we think about primary neurological injury, and the more classic diagnostic that comes in mind is subarachnoid hemorrhage, sometimes TBI. But more recently, and maybe a little bit less slightly widely used, TCD has also emerged for systemic illnesses such as cardiac arrest, hepatic encephalopathy, any types of shock, really, in patients supported by ECMO or ventral assist device. And if we classify application by more physiologic indication rather than diagnosis, classical ones will include vasospasm and cerebral circulatory arrest. Assessment of ICP, CPP, autoregulation have also become more common. But in addition to these, point of care focused TCD examination can be used in the PICU as a neuromonitoring tool and to guide individualized treatment. And focused TCD is of a particular interest in this setting because it allows a surrogate assessment of the adequacy of cerebral blood flow, as well as screening for increased ICP or low cerebral perfusion pressure and assessment of cerebral autoregulation. And all of these might help dynamically guide and individualize the titration of, for example, blood pressure and manipulation of carbon dioxide level. And some people have described this application as part of a broader, like, whole body or head to toe POCUS assessments. And this helps us move from empiric threshold towards more personalized targets that are driven by pathophysiology and are dynamically reassessed throughout the disease evolution. And for systemic disease, we all know that the brain is an organ, but we don't really monitor the brain like other organ dysfunction commonly. It's really surprising that we have so little feedback on how we're perfusing the only organ for which we have like zero replacement possibility. And so while not perfect, TCD can offer a window, a piece of information about the adequacy of cerebral perfusion, similar to how we use urine output and creatinine for the kidney. So those are two also imperfect markers, but that we still find useful to inform on renal perfusion and function. For primary neurological injury in the ICU, by allowing a surrogate assessment of cerebral blood flow, which is a very different piece of information than pressure itself, TCD helps our understanding of complex brain injury and it may helps us infer pathophysiology and help develop more tailored management strategies. So here are a couple of short examples on how serial-focused TCD assessment can inform management. So this was a 3-month-old male post-prolonged out-of-hospital cardiac arrest. So the first TCD on the left was taking about 30 hours from arrest and shows really awful waveforms with complete diastolic reversal with very low flow, mean flow velocity. Cerebral resuscitation with progressive map augmentation and some osmotherapy was undertaken with serial close by TCD after each intervention. And in the last TCD on the right, 4 hours later, there was no more reversal and mean flow velocities had almost quadruple, but the waveform remained very, very, very abnormal with discontinuous waveform. This is another cardiac arrest case where TCD uncovered cerebral hypoperfusion at like quote unquote normal or even high normal blood pressure goals. Um, and so map augmentation was done under close TCD monitoring, and the TCD waveform went from very resistive with early diastolic reversal and very, very low mean flow velocities to an almost normalized waveform in less than 3 hours. This is a 14-year-old with acute liver failure and grade 4 hepatic encephalopathy, very sick, intubated, CRT, comatose. But we know that these patients have many confunders, right? They accumulate meds, they have hyperammonemia. And so TCD was done for neuromonitoring and showed a resistive waveform with a high PI, but a somewhat preserved diastolic flow, which was kind of reassuring in the context of this very sick patient who might have herniated or have like a diffuse injury. She got transplanted like a few hours after this TCD and then had good graft function, but the team was really worried because the patient wasn't waking up after 36 hours without sedation. And so TCD was done at that time and showed a completely normalized MCA waveform, and she eventually woke up and had a good neuroinvolution. Even in patients that already have invasive ICP monitoring, TCD can add value because it aims to assess cerebral blood flow and not pressure itself. And so it adds the unique possibility of helping distinguish the driving force behind an ICP crisis to help tailor therapies. And this can be really helpful because what you see here is an example of the second tier ICP therapies in the TBI guidelines. We have no clear guidance on how to choose those therapies once we're at that refractory point, and those target very different mechanism. And this choice is usually currently provider or center dependent, but we have TCD might provide a way for it to be more rational. And so, if you have by differentiating a perfusion limiting from a perfusion driven ICP crisis, and so perfusion limiting crisis, like with edema or mass lesion, the waveform will be resistive with a progressive diastolic blunting or even reversal. And this, you might want to consider more edema-directed treatments, BP augmentation. It might be more appropriate than choosing hyperventilation in this context. And in contrast, if you have a perfusion-driven ICP crisis that might be caused by hyperperfusion and impaired autoregulation, you might see a hyperemic waveform with high velocities, low PI, a linear ratio less than 3. And in these cases, you might want to consider going for mild hyperventilation or mild hyperthermia instead that going with aggressive MAP augmentation. TCD can also help us avoid iatrogenic harm. For example, excessive hyperventilation leading to compromised cerebral blood flow. And this can be useful if you use hyperventilation for refractory intracranial hypertension or to monitor the CO2 reduction after ECMO cannulation for respiratory failure. So those cases kind of underscores how serial exams allow for close monitoring and feedback on the effect of our ICU therapies on the brain. So to review some key literature, I'm gonna share some results of a scoping review that we recently completed with colleagues from the PNCRG on clinical application of TCD in the pediatric acute care setting. So this includes mostly PICU, but also other acute settings like the ED, inpatient ward, perioperative studies. So overall, 11 physiologic indications for TCD performance in acute care were identified, and specific subcontexts of use were specified within each. So, for example, for the physiologic indication of cerebral circulatory arrest, TCD could be used as studied as an ancillary test for brain dead in some studies, whereas in other studies it was more like serial TCDs to optimize the timing of official brain dead testing. And so a detailed summary of the key evidence and findings is provided for each physiologic indication in the manuscript that should be out shortly. And here I will only really briefly review some key points for selected indications. And so for ICP, CPP, the major takeaways were that there's good correlation between TCD-derived non-invasive, like quantitative non-invasive ICP estimation and invasive ICP. However, the main problem is that there's like really a wide confidence interval. And this is why TCD does not replace invasive ICP monitoring when it's indicated, when you need an ICP number. And this makes sense because TCD is a surrogate for cerebral blood flow, which has a relationship with ICP, but it's not a pressure measure. And secondly, an elevated PI and a low diastolic velocity has a high predictive value to detect ICP more than 20 or CPP less than 50. So sensitivities were over 80% in the vast majority of studies that were included. Of note, in TBI, the accuracy seems to decrease after 24 hours post-injury, which kind of makes sense because we know that a proportion of these patients will develop hyperemia around day 2 to 4, which can definitely confound the relationship between PI and ICP. And so this kind of semi-quantitative rule-out method can be useful to help for screen for increased ICP when invasive monitoring is not available or contraindicated, or to triage the indication for invasive ICP monitoring in borderline cases. And finally, TCD findings that are suggestive of intracranial hypertension and hypoperfusion correlate with worse outcome in various conditions, so TBI, cardiac arrest, liver failure, CNS infections. For vasospasm, while TCD is well established in adults, there's very limited pediatric data. Some of the things we found was that TCD criteria for vasospasm were widely heterogeneous and there's no widely validated pediatric threshold. So in the scoping review, about half of the studies used fixed adult threshold and the other half used age-specific norms like mean flow velocity more than 2 standard deviation. with three quarters, including the Lindegaard ratio. And importantly, the Lindegaard ratio threshold of three is not widely validated in pediatrics currently. So there's definitely need for further evidence. Importantly, there's also a lot of uncertainty about the clinical impact of TCD-informed vasospasm management. So who should be systematic screened in pediatrics? We have different epidemiology than adult subarachs. What are the threshold for additional imagings? What are threshold for interventions? But nonetheless, it seems from the small evidence that we have that TCD diagnosed vasospasm seems to be associated with poor outcomes, and so more consistently in subarach and CNS infection than in TBI. For hyperemia, the most frequently reported TCD criteria included an MCA mean flow velocity more than 1 to 2 standard deviation from age, low pulsatility index, and in some studies, a Lindegard ratio less than 3. Hyperemia was quite frequently reported, and there was frequently an association with poor outcomes in various conditions. For TCD goal-directed therapy, meaning when TCD is used to titrate the therapies with the aim of normalizing or improving the actual cerebral blood flow velocities or the TCD waveform, we found several descriptions of this for individualized cerebral hemodynamic optimization in various clinical scenarios. Some specific example of applications included guiding blood pressure goals and hemodynamic augmentation with vasopressors, adjusting the pace of rewarming post-therapeutic hypothermia, guiding anti-edema therapy escalation without ICP monitoring, invasive monitoring, optimizing the bypass flows during cardiac surgeries, and a lot of other examples. And so the most frequent goal that was reported was kind of reversing sonographic evidence of cerebral hypoperfusion. There was different threshold for that in different studies. There was three small studies that had some association or linked TCD goal-directed management to some improved outcomes. The other application will be discussed in greater detail by my colleagues later this morning. And some other relevant consensus statements to mention include this practice recommendation for TCD in critically ill children that was published in 2020. It outlines best practices for technical performance, interpretation, reporting of TCD, and the PICU. An important takeaway from this consensus was kind of officializing the recommendation to use age-specific normative values to interpret pediatric TCD and defining abnormal cerebral blood flow as more than 2 standard deviation from age norm, which is an important difference from adult practice, right? That uses kind of fixed thresholds. The ethnic POCUS working group also included cerebral POCUS in their 2020 guidelines on point of care ultrasound in critically ill children, listing detection of changes in cerebral blood flow, ICP, cerebral circulatory arrest, and vasospasm as a recommended application. But while TCD is increasingly used in critical care for various indication and as part of neuromonitoring strategy, there's no consensus on the distinction between point of care and more diagnostic or consultative TCD and their appropriate context of use. So this is in contrast for like cardiac echocardiography where we have more clear guidelines. And we found that published studies do not explicitly differentiate the two. And so the terminology point of care or POCUS or focused TCD was mentioned in only 3% of original studies included, and mostly in more recent studies. The absence of a clear distinction really impairs the analysis of available research and contributes to an absence of standardization and engenders concern about like the scope of practice and quality assurance. And this might explain why the uptake of neuropocus kind of lags behind other ICU POCUS application like the heart and the lung. And so providing a common terminology appeared essential to move towards next steps like building educational frameworks and quality improvement processes, and might allow for clearer classification of research studies. To address this, with the support of the PNCRG TCD focus group, we just completed a Delphi study with 69 pediatric TCD experts across 12 countries. So this is unpublished data. The manuscript is in preparation, and I'm going to share like a high-level summary of some of the findings, but stay tuned and in the next few months for the details. And so for the first objective, which was the definition and distinction between POCUS TCD and diagnostic TCD, consensus was reached on 35 statements spanning 6 important domains of POCUS or ultrasound definition. We won't go over all of them right now, but as an example, for the domain workflow and setting, there was consensus that POCUS TCD is performed and interpreted by the patient's treating provider and interpreted in real time at the bedside, whereas diagnostic TCD is performed and interpreted by a designated clinician or team at the request of the patient's treating team, with the images subsequently interpreted by a designated physician. And another example for the domain purpose, goal, and intent, there was consensus that POCUS TCD was a focus assessment with the goal of answering a predetermined clinical question in real time, whereas diagnostic TCD implied a standardized and predefined exam protocol to gain extensive diagnostic information. The consensus also addresses potential differences in four other domains, including the scope and extent of the TCD exam, so windows, vessels, scanning details, type of interpretation, equipment and modality, POCUS versus diagnostic machine, imaging versus non-imaging TCD, operator specialty and training, documentation, reporting, and archiving of images. Um, so for the second objective, which was to determine appropriate physiologic indication for POCUS versus diagnostic TCD, consensus was reached on 34 statements over 11 physiologic indication. So as an example, for cerebral vasospasm, there was consensus that diagnostic TCD was preferred if available, but that POCUS TCD could be appropriate to screen or as an adjunct surveillance tool. Whereas, for example, for that's not yeah, that's for TCD goal-directed therapy, POCUS TCD was preferred. And so this was done for each of the 11 physiologic indication identified in the scoping review. So more on that. So stay tuned in the next few months, and hopefully this helps move forward. There's multiple research gap that remains. I think to resolve some of the conflicting data, like the TCD and ICP association or association of TCD patterns with outcomes, future research will really need to systematically take into account age-specific values, timing from injury, underlying diagnosis, because as stated, the pathophysiology of an ICP crisis and thus the TCD correlate may differ. Um, Basic research topics might include the more research on continuous TCD monitoring devices. And then clinical research topics, there's a lot of them that are needed. Some next step will include to study the clinical impact of TCD guided management and individualize hemodynamic management, to determine who benefits from systematic vasospasm screening in pediatrics, given our particular epidemiology, to evaluate the performance of TCD for neuroprognostication in various conditions, for example, cardiac arrest, and to study the clinical impact or usefulness of TCD for risk stratification, or, for example, for triaging of invasive monitoring. One of the main gaps in this field is education and training. There's good resources currently available. I also train at Wake Forest as a formal course. Typically, those courses have a little bit more of a focus on adult population and diagnostic TCD, but some have evolved to include some pediatric and critical care focused content. But we really need standardized training pathways for POCUS TCD in pediatrics. Some recent initiatives include an open pediatrics neurosonography model that we launched in 2024. Our UK colleagues, including Bogdana, just are launching now an accreditation pathway with Fusic and Cactus with train the trainer days, and have really made a great work on that. And we're also working on a PNCNG endorsed POCUS TCD course for next year. But really looking forward, I think international collaboration will be key to enhance standardization in this field. And another important gap is competency requirements. And so for diagnostic TCD, the current general TCD certification like RPNE, is that adequate, or as my colleague said earlier, do we need pediatric specific competencies? And then for POCUS TCD, this is an important next step that will need to be defined. For both diagnostic and POCUS TCD in pediatrics, clinical implementation really remains a challenge, and we need to clarify the who, the how, and ways to increase the workforce for both workflows. Credentialing requirements really need to be clarified. So for diagnostic, we talked about maybe the need for pediatric specific credentialing or not. For POCUS TCD, like how does it fit with general POCUS credentialing? Consensus statements, as alluded before, with further like as further evidence is gathered, specific consensus on vasospasm screening in pediatrics and TCD goal-directed therapy will be relevant priorities. And then ultimately, internationally endorsed society guidelines, including TCD specific guidelines, but also integration of TCD in other major PICU guidelines like TBI, cardiac arrest, septic shock, will be needed. That's it for me. Thank you for listening. It's a bit fast. It's a wide subject, but hopefully that's helpful as a teaser.